Okay, I think we are good. So, Saya, well, you'll start us, but let me do the greetings. Good morning, the people on this side of the oceans. Good evening, the people back home. Welcome to this conversation on erectile dysfunction. I know because of the sensitive nature of the topic, if you're afraid your true name will be seen out there, your permission to change it, and you can put an avatar. But it's one of the reasons we're talking about it. So Saya, as usual, introduce the topic properly to us, and we'll take it from there.
Okay, hi everyone. My name is Saya, and totally honored to have all of you people here. And for those who'll be watching it recorded, also welcome. I work as a transitions coach. I simply just help people build new maps to navigate the new worlds of career, relationships, and work they get into. So today's intro is actually very short. In many cultures, and because we straddle through domiciled in Africa and having moved to the West, being masculine is associated with the penis. And in certain words, even in pop culture, that equate guts to your scrotum, the expression is in that side. It therefore means in many cultures, therefore, when individuals are not able to, the functioning of the male reproductive system gets into challenges, what is affected is not just purely health. It's not just, it's not the same as a broken toe or a blocked nose or a misfunctioning liver. It boils down to the question of identity. And not just the identity of the man who is not up to scratch as far as the functioning of the reproductive system is concerned, but also of all those attendant to him, whether it's the spouse or children, are either affected or involved in this entire thing. It is Bishop Maponga who puts it and say, and his metaphorism of the penis, he says it's a cable, and it connects the past, meaning the ancestors, the genes that you've had, and the future, which means the progeny you're able to procreate through the use of the male reproductive system. And therefore, when you think about metaphorisms like that, you imagine when there's a problem with a cable that is not able to relay its work very well, there's an honest sense of angst and a sense of trepidation that comes with it. In African tradition, when a man was having erectile dysfunction and therefore not able to do his sexual duties accordingly, it was covered by behavior like colluding with a man's brother or somebody of consanguineal relations so that they would be able to fulfill the matrimonial duties to the wife and even possibly be able to procreate. In a world where we no longer live in the villages we were born in, such measures are not possible. And also in a world that has become imbued with more Islam, also such remedies are viewed as immoral. So still the question does not end what needs to be done. If that was not enough, we are witnessing a generation where I remember having a discussion that I alluded to early in the week with a young person, very young, in their 20s at that time, earlier 20s, who was already using Viagra at that point. And he was not married. Two, I was wondering, why are you already using Viagra at this age? Because we've come to associate it to be an old person's pill. And it turned out that in that particular circle, or in the younger circles, they treat the use of Viagra as performance enhancement rather than performance creation. So in an over-sexualized generation that we are probably witnessing or living through, the use of like performance enhancement drugs like Viagra, Cialis, and the rest is setting up more and more young people to become victims of erectile dysfunction. And I don't think they're well prepared, both psychologically as well as physically, to live through the repercussions of the same. So if this was 2 decades ago, when I'd be introducing this topic, would probably be thinking about men of a certain age and beyond. But sadly, right now, we're having to think about men way younger in the spectrum, having to live with erectile dysfunction and going through it. Naturally, it's a question that brings an amount of shame, quite an amount of secrecy, and a lot of disruption, both on the social end. Now, we have 2 ways to deal with it. One is ignore that it is not there, yet we still know it is, and it'll eat away like a cancer. Or B, do what we like to do at Authentic Dialogues, which is have this discussion. It could be uncomfortable because it's not a very normal African thing to do, but I think it's a necessary conversation to have. So with that, one final thing I needed to say, the sensitivity around a topic is normally within the African setting can be judged by the amount of metaphorism that is thrown around. When people need food, they'll generally say, I'm hungry, I want to eat, because food is not treated too sensitively. But you do notice that around the question of sex, human sex and sexuality, the metaphors begin increasing quite dramatically. And on today's topic about erectile dysfunction, you begin noticing how much metaphors are used. Words like the engine is not roaring, the anthem is playing, but the flag is not going up, the things are not happening, the umbrella is not opening. So which speaks A, to the discomfort that people have to handle this head on, but also B, the level of sensitivity that we have thrown around it. So today we need to tear away from the metaphors and be able to go through and understand the issue, both at a medical level, but also at a psychological level. And I hope that by the end of it all, we can be able to have the courage to face and, importantly, to deal both on the preventative, curative, and promotive level. Over to us as we have this authentic dialogue. Back to you in studio.
Thank you, Sayam. So let me call up Prof. You're up. So what exactly is erectile dysfunction? Let's start from the abnormal and then we see. What's erectile dysfunction?
Thank you, and I hope you can hear me. Erectile dysfunction is erection failure. It is failure to get an erection to satisfy your partner sexually. And medically, it is a medical condition. It's a disease which needs to be treated. And we normally make that diagnosis if one has consistently failed to rise to the occasion for a period of up to 6 months. They are trying to have sex, and in most of the cases, they cannot get an erection to have penetrative sex, or midway the erection goes, or the erection is too weak, soft to have penetrative sex. So that is what we call erectile dysfunction. Of course, there are many things around that definition, biological, psychological, and social. I think Saya has already talked about some of the psychological and social things related. In sexual medicine and sexology, we look at the full person. We look at the biological factors around the problem, the social factors around the problem and the psychological factors around the problem, which also means that it's a complex problem. It needs to be looked at as complex because it has social, psychological repercussions, while at the same time, social and psychological factors can also cause it, in addition to biological, medical factors, which we know cause it, and we can talk about that as we go on.
So because this is dysfunction, could you just do a quick rundown of what erectile function is then? And if you want a picture, I can provide one from the internet, or if you have a model, that would be good.
Well, I can describe what a normal function is. A man is sexual just like a woman, and they think about sex, they imagine sex, they dream sex. When they think about sex and dream sex and visualize sex in their minds, their bodies respond. The brain responds by releasing some chemicals which are transmitted to the sex organs, and they get an erection. A lot of men wake up in the morning with an erection. When they are with a partner, the looking at the partner, men are very visual. When they look at the partner, that alone can cause an erection. When they touch the partner or when they are touched by the partner, that can cause an erection. Just being in a place where sex is possible, a sexual area where you start imagining sex, like being in the same room together, can cause an erection. So that's a normal function. And then when the erection happens, well, a lot of things will have happened before penetration, but when the penetration time comes, then this person is able, the erection is strong enough for this person to penetrate the vaginal canal, and they're then able to go through a circle, which in sexual medicine we call, that back and forth, the process, the activity of sex until they reach orgasm. And then they get a resolution of that erection. And they have a period when the body just relaxes and they can't get an erection until it recovers again. So that is a normal function.
Oh, thank you. Saira, do you have any addition on the definition and the normal function? So far, what we've talked to, so far what Prof has answered.
Yes, I think he's defined it already quite well. It's the inability basically to maintain an erection to satisfaction. And I think that's where the definition comes in from most societies, yeah. So if you look at the stages and you're looking at typically like 4 stages of sexual function, which starts with desire, which was what Prof already described, which moves on to arousal, to orgasm, and eventually to resolution. And when we are looking at erectile dysfunction, then that's usually at the point of arousal that comes in. And what additionally I would like to add on to this is that these functions are all controlled by a lot of factors, and it is not only related to the structural capacity of the individual, and that's where the hormonal aspect comes in, the psychosocial aspect comes in, and the aspect of the vascular, like the blood supply to the organs, and the correct or the right functioning of the nerves also comes in. So it's like a play of multiple factors that eventually lead to a healthy or a successful or satisfactory sexual encounter.
And we can break that down actually. When you say the nerves must be okay, the mind has to be right. Someone has to be at peace in their mind for them to have sexual feelings. If you have a problem with your partner, for example, or if you are stressed, could be because of money or other things. During COVID, we did some tests, some studies, and we found that many men were lacking erection. Reason because they didn't have income, they were holed in the house the whole day, they were stressed. So when the mind is not okay, which can be psychological and even psychiatric, erections don't come. When you have a problem with your partner, there is a blockage that happens, then you can't have an erection. And then all those, the vascular issues you've talked about, the neurological issues, there are a lot of diseases that will affect those systems, especially as we age or as we adopt unhealthy lifestyles that then affect erections, because maybe the vascular system, the blood vessels are clogged because of too much fat and other things, then erections don't come. So it's a very complex problem. And in fact, it can be used as an indicator of good health, both psychological, social, and physical health. And so when you don't have an erection, it's very easy to say it is a symptom of other things happening, either socially, psychologically, or medically.
And since, so is erectile dysfunction, because we females have erectile tissue, why isn't our dysfunction called erectile dysfunction? Is that just a male terminology?
Yeah, and I know today we are not talking about females, but females also do suffer lack of arousal. The only difference is that their erections are not visible. They more have lubrication and the whole body getting ready for sex. For a man, it is very obvious because the erection will not be there. For a woman, it may be that they don't have lubrication, they are dry, and the sex becomes painful. So they can't get aroused. So it is the same thing.
Oh, we'll cover the female ones next year. So today we dedicate this conversation to the men. Okay, I know you've alluded to the causes of erectile dysfunction, but could we just go systematic, and if you could emphasize on what's plaguing our men in Kenya, as in what are the causes? If you can just go through them systematically and then just see.
Okay, so we can classify them into biological, psychological, and social factors. Biological factors, there are a number of physical diseases that end up with erectile dysfunction. Let me give examples. Diabetes is very common. When not managed well, it will kill your nerves. It will also cause damage to your blood vessels. Remember, an erection is accumulation of blood in the blood vessels of the penis. Someone needs to mute. Okay, thank you. Yeah, so when the blood vessels are affected, then blood cannot accumulate in the way it should, and you lack an erection. And that happens in many diseases. Diabetes will affect both blood vessels and nerves. Hypertension, high cholesterol, especially if you combine those three diseases, the damage becomes quite a lot, and you get erection failure. Of course, with time also, you start to get other problems in the kidney, the heart, and so on. But erection failure is normally the first thing, the first symptom that tells you that diabetes, hypertension, high cholesterol is starting to affect you. And there are many other medical problems, neurological, sometimes just the nerves around the pelvis being pressed by something or in the back can affect erection, because you need the nerves to be working well for you to have an erection. Some medicines which we use, sometimes even to treat hypertension or psychiatric medicines, can have an impact on the functioning of the sexual system. I think my colleague already talked about hormones. Testosterone, lack of testosterone or low testosterone is a very common cause of erection failure. Unfortunately, men don't normally check their testosterone routinely. I think in this part of the world, we don't normally do annual medical sexual checks. So most men don't even know that they have low testosterone. There are other hormones such as prolactin, thyroid hormones. When they are not okay, then you get erection problems. So the biological medical problems are multiple. Psychologically also, we've talked about some psychological problems, but there are a lot of psychological issues that people go through every day. At the place of work, in investment, even religious issues. When psychologically you're thinking that you're going against your values, you're going against your religious beliefs, sex may not happen. And so we always say, for healthy sexuality, ensure that your actions and your values are matching. The moment those two are in conflict, you get psychological problems and you're unable to get an erection. And there are other many psychological problems. Then there are social issues. We've talked about relationships not working well. I think recently, some of the studies done in Kenya and other parts of Africa show very high levels of infidelity. Infidelity is one of the social problems that we deal with in a sex clinic, because people are fighting because their partner is not faithful. And when that happens, the conflicts in a relationship become quite intense and sex cannot happen. People just fail to have erections. And I've also noted in my patients that sharing love is very difficult. I know polygamy is acceptable in some communities, but what I've seen, a lot of men in polygamy, in polygamous relationships, tend to have what we call situational ED, situational in the sense that they are able to get erection with one woman or one partner, but not with another partner. So sharing love, I think, becomes very difficult. There are other social things like just alcoholism, and also lifestyle issues. When people are not exercising, their BMIs are not okay. They may not be having any disease, but we've seen a big body weight just by itself can cause erection failure. So there are multiple things. I think I can leave it there.
Saira, who's seeing you for erectile dysfunction? What are the causes from your end as an endocrinologist?
So who is seeing me is an interesting question, because like Prof said, first of all, it's, I mean, not even beyond what we heard earlier. Still in the developing part regions in Asia, I've experienced the same thing in some facilities in Asia and also in Kenya. The health-seeking behavior is a problem when it comes to sexuality. Yeah, it's considered as a taboo to even talk about sexual function, especially if they see, like, if it's a male patient and seeing a female specialist, they'll never really easily come out and say, "Oh, this is what has brought me." So that we hardly find. But in practice, I mean, as far as diabetes, I see majority of my patients are those who have diabetes, right? And I deal with adults. So I'm an adult endocrinologist. So most of our patients, the bulk of it is those who've got diabetes. So we have to actively ask for erectile dysfunction in these patients who have got diabetes. And you find that at least up to 50 to 75% of patients, especially with type 2 diabetes and those who have got a long-standing diabetes, poorly controlled diabetes, and comorbidities like Prof alluded to, including hypertension or high cholesterol levels, do tend to have some element of sexual dysfunction, especially erectile dysfunction when you're looking at men. And exactly what he was talking about is the aspect of evaluating the patient holistically, other than just looking at the erectile dysfunction as a physical component of it all. So that's one group of patients, which is the bulk of our patients, the patients who've got diabetes, and especially those who have long-standing diabetes, type 2 diabetes. The other group of patients that I see a lot of erectile dysfunction and overall sexual dysfunction in is the group of patients with pituitary tumors. So especially if they've got surgery done to the pituitary gland, which is the master endocrine or hormonal gland, which produces all these hormones, which then control the rest of the hormones in the body. He talked about testosterone. It is regulated by hormones produced in the pituitary gland. He talked about other than the male sex hormones, there's also other hormones which do regulate the function of the erection. That's like the thyroid hormone. So we get also patients, if they've got pituitary problems, or directly if they've got thyroid problems, they would still come with sexual problems. Then there's the whole aspect of prolactin production. And if there's excessive prolactin production in men, it could present as erectile dysfunction primarily. So in the endocrine section, that is what we see. Again, there's a condition known as Cushing's syndrome, where you've got excessive production of the stress hormone. So stress itself is associated with reduced sexual drive. But in addition to that, there's also the element of like the endocrine or hormonally induced excessive cortisol production, and that can impair the sexual drive. And on the other hand, even very low cortisol levels can also impact on erection and overall on the sexual performance of both males and females. So we have a very wide array of these patients who come to us, and actively I've realized that we have to ask for it instead of patients coming forth and telling us, this is what I have. And they don't even usually associate the aspect of the medical components versus the, the sexual component. And one thing I'd like to mention at this point is that the cardiovascular aspect of erectile dysfunction. So like Prof mentioned, and we talked earlier, that the sexual function or the erectile function is a product of having normal blood vessels and having normal nerves, in addition to hormones, in addition to the structure of the whole erectile system, which includes the penis itself, but also the testicles, the prostate, and all other factors that are associated with achieving that normal sexual function. And so the thing is that when there is a problem with when we see a patient coming in with erectile dysfunction, and why that's also another reason why it's so important to ask for it, is because once we see that patient, whatever is happening in the sexual organs is also happening in the other blood vessels of the body. And that includes the heart. And that is why whenever a patient comes to me with erectile dysfunction, then I start getting a little worried and concerned, because then that means that there's probably the same issues going on with the blood vessels of the heart and the other organs of the body. And actually studies have shown that when you do have erectile dysfunction, you have to look for cardiovascular risk factors, because it actually increases your chances of early cardiovascular death compared to the general population. And that is why it's a very important topic for not only the urology aspect or reproductive aspect, but also from the cardiovascular aspect.
And what does age have to do with it? Old people who are healthy raising their flag to the necessary standards, or it comes the same way my white hair has come? Prof.
Yeah, so age definitely has an issue with erectile dysfunction for various reasons. Even if you didn't think biological, I've seen a lot of men get busier with investment and social things as they age. And so they have little time to just be romantic. So they lack energy to concentrate in romance and things like that. But biologically, as one ages, the tendency to develop diabetes, the tendency to develop hypertension becomes higher. They also become inactive. The tendency to have high cholesterol gets higher. And so these diseases impact on the sexual function. Many men also will have hormonal problems with age, especially testosterone. But that said, because of the different causes of erectile dysfunction, we see erectile dysfunction across ages. I have had cases where people come from honeymoon, break their honeymoon to come and see me because things are not happening. And mostly in younger people, It is because of lack of sexual experience. It is trying to deal with values that they have held for a long time around sexuality. You know, in Africa, sex in many families is portrayed as a bad thing. And so they're just starting off their sex lives and they're realizing, am I really doing the right thing? Subconsciously, they may not, take sex positively. And so very early, you find erectile dysfunction for various other reasons. But as people age, the reasons change and they become more medical. In between, the social factors become heavy. The relationship factors become heavy. I think most relationship problems happen around between the age of 30 and around 50 is when most couples have a lot of relationship issues in my setting. That is when infidelity is also very common. So you find erectile dysfunction happens across ages. The reasons are what differ from age to age, but of course, because the reasons in higher age groups are more, then you find more cases of erectile dysfunction in older age groups.
Sir, because Prof has brought in the religious angle, and you can put on your fake religious hat now, what are you doing to address couples who've not been exposed to sex and they have to perform on the night of the wedding and thereafter because of the religious shame and they've been scared about, as Prof said, that sex is bad manners?
So the unfair part of your question is it almost seems general. So not all religion condemns sex, but I do get the place that it's coming from. So the two things is, one, in proper premarital counseling, I had the privilege of also having that both group and individual counseling. There's a lot of candid talk about sex and its kinetics and reframing the mindset and how to prepare for that. So there's a lot that happens in proper premarital counseling. So if the minister who's preparing you for marriage is worth their salt, they'll be able to walk you through that. The number two is there's a lot of the books written on sex. The one that actually comes to mind is called the Art of Marriage. It's a book that is written from, as a Christian, it's written from a purely biblical worldview and talks about sex in its all wholesomeness, both from mindset to kinetics to motions and stuff. So there is material that is put in the world that is written with a biblical worldview that speaks to sex in its all proper way. And then, and I'd say 2 points, but a third small addendum is the good sermons actually out here. I've listened, and a lot of family life programs that address the perception and practice of the negative, limited sexual belief. And just to remind people, sex is not a good thing. Sex is a God thing. It wasn't invented in Hollywood or something that was conjured by men, but at least from the biblical worldview, the command to be fruitful and multiply, which was a command to have sex, preceded the command to eat, preceded the command to keep the Sabbath or to even take care of the garden. It's basically the first thing they were told when they were created, at least in the Genesis account. They were told, be fruitful, multiply, fill the earth, replenish it, subdue. So in proper preaching, the holistic view of sex is redeemable. And I have preached thus, and I know many people who've preached a more redemptive view. And heck, there's a whole book of steaming romance in the Bible. It's called Songs of Solomon, that is both descriptive and celebratory in its analysis of sex. It talks about sex in very descriptive ways. It celebrates the passion, the process, the heat of romance and everything. So all those combined, I think uniquely, a proper leverage of faith, in this case, speaking from the Christian worldview, results into a more healthy, can result into a more healthy sex life. A final point is this: Prof has pointed out that there are non-medical links to erectile dysfunction, and many of them have to do with feelings of worth, feelings of identity. And so, like you see, like speak about, as men grow older, we're trying to make more money, we're hustling and worrying about many other things. And often it's because we feel that those things will define us, or those are the things that give us a sense of security or of identity. But because of the ability of faith to give us an anchoring and a sense and a source of identity that is not pegged to money or other forms of performance, it is a fitting panacea to keep somebody calm and clear enough that they can then have the supportive physiology to help them have a proper sexual experience. And then finally is the plethora of mentorships and counselings that people go through, whether it's Wamama Wagud or men's groups or testosterone zones, you know, whichever gisty ways they are branded. Some of the topics that are talked through there are sex and how proper weighting helps you be able to enjoy proper sex, how proper view about God and about humanity is important in helping you reclaim proper sexuality, and how overcoming habits like masturbation or self-abuse increases your vitality and ability to enjoy sex when it comes. So I think within the Christian worldview, a proper and the healthy side of it is able to equip and address many of these issues of erectile dysfunction.
Thank you. And back to you, Prof. Now that Saya has brought the issue of masturbation, what's the effect of three things before they disappear from my head? Masturbation, porn, and for our weightlifting siblings, all the plethora of stuff they take to get to titimua their muscles. There's no better word than titimua. So whatever,
Well,
yeah, go ahead.
Yeah. And yeah, so I think what I would like to say is that sexual values are very diverse. And the Christian view is there, the Muslim, and then there are others. And what I've also seen is that there is always a conflict between what people believe and what they practice. And that conflict is the source of erectile dysfunction sometimes, when values and practices don't match. So there are very many values based on your religion, your culture, your family of origin. There are values people hold. So things like masturbation and porn, for example, people hold different values around them. Even sex positions, people hold different values around them. I always go to churches, for example, I'm called to talk to couples. And people always argue around, should we have oral sex or not? It's all about values. Now, what I would say is people need to match their values and their practices. And I know values do change. At some point, you have a value which can change. When your value has changed, you can match it with a practice. So someone who was previously not religious can become religious. There are others who are religious, then they drop religion. And then their values change. Just make sure that your value and your practices match. And that is one way of avoiding erectile dysfunction. When there is a conflict internally, then you get problems. Erectile dysfunction being one, and there can be many, many others, even premature ejaculation and so on. Yeah.
Sarah, do you want to talk about the illegal drug use especially by our weightlifting siblings? Are you seeing that in your practice?
Yeah.
Sorry, go ahead.
You asked about that, and the use of sex enhancing drugs, I think, is not a new thing. In fact, it did not come with Viagra. If you go to African communities, they have these herbs people chew. I think if you come from Kenya, there is a common one from Western Kenya that everyone knows about, mkombero. And each community has something they believe if you chew will enhance your sexual function. And in fact, even foods, people look for foods that they think will enhance their sexual function. I think in Eastern Africa, in Uganda, and even in Kenya and other places, they talk a lot about ground nuts. Of late, I'm seeing a lot of talk around watermelon and eating the watermelon seeds, and so many others. And so the desire to enhance sexual function has always been there. And I think Viagra came when this already exists, and people found refuge in Viagra and other related drugs. I think the reason why this happens was discussed at the beginning of this session, that sexual vitality, it is closely associated to a man's feel of confidence and success. And so the fear that I can fail sexually can crush a man totally. Their ego can go, their confidence can go. And it doesn't just affect a sexual relationship, it affects every other thing. A man will go into alcohol because their sexuality is failing. They will stop investing because their sexuality is failing. I've seen men walk out of church and other religious settings because their sexuality is failing. And so the ability to perform sexually is ingrained in our definition of a successful man. And that is why across the ages, people have tried to use enhancers to perform sexually.
Saira, do you want to add anything on that?
Yeah, I think what you were also alluding to is these muscle building drugs that are being used. So basically these are forms of what we call as anabolic steroids, which are actually used. Unfortunately, we have these available over the counter for some facilities. Which is quite unfortunate, because these ones, especially, you see, the muscle builders are usually the younger people. And when these are used for long term, then the problem with this is that other than building muscles, they also end up suppressing your pituitary and hypothalamus to be able to function appropriately. And that what we call as hypogonadism, and eventually could lead you to having a significant not only capacity to have sexual, like erectile function, normal erectile function, but also the capacity to reproduce later can be compromised if they're used over a long term, because they suppress your sperm production as well. So clearly, yeah, and in as much as thankfully we are not seeing too many of these, probably they are going to the urology colleagues, and less so to the endocrinologists, but we do end up seeing, we have been seeing this of late, as from other colleagues also that have reported that this is increasing. And this is not only in Kenya, I think across the world, this is an issue that is coming up with the use of anabolic steroids.
Prof, I know you mentioned the foods and the mkombera and everything that we're eating. I'm just wondering what other what myths surround erectile dysfunction, and if we could address those.
I think for me, the biggest myth is that it's not a medical problem. The time people come to me, they have really suffered and they have tried a lot of things. There is a belief that when erection fails, it is not medical. People talk about witchcraft, people talk about a lot of things. And the they try very many things before they come for treatment. And sometimes when they come for treatment, that is the first time we are making a diagnosis of diabetes. Meaning, if they came earlier, we would have sorted this diabetes and they would be okay. And the damage to other organs would have been controlled. And so that myth that it is not medical, if we can do away with it, and then have people come and we discuss the possible causes and go to the root causes and make a right diagnosis, that would really help.
Saira, on your side, the myths, especially the ones that miffs you the most.
So I think the aspect of it not being able to be treated or making someone any less of a man, that is one thing that I usually try to address a lot in the clinic. And that is the whole reason why people don't talk about it, and that it's something that shouldn't be talked about. I think that really needs to be looked at. But the others, I think, is exactly like what Prof has alluded to, that it's not a medical condition and that it's something which shouldn't be addressed. And I think that's crucial, because we do end up getting a lot of patients. So if we ask, we definitely find, even if it's mild, unless it's someone who's just recently been diagnosed, but more often than not, we find, erectile dysfunction. So the myth is around, basically that the fact that it's not treatable or it makes you any less of a man. And I don't think that is true.
Because go ahead. Sorry.
This myth actually also goes to policy level. If you are unlucky to have erectile dysfunction and you want to use your insurance in Kenya, most likely it will not be paid for, because people think that you're just looking for fun and enjoyment of sex. And we've tried to talk about this. We've said these are people who are sick. Employers don't want to pay if it is, direct payment by employers. They think you just want to have fun. They don't know that if erection is failing, even productivity at the place of work is affected. So we need to do a lot more advocacy around this, that sexual health problems are really medical problems, so that people understand this across the board, whether it is financial, financing for health, whether it is health products and how we manage and control them. I think there is work to be done there. Right now, as a sexual health person, there are a lot of gadgets that we lack in Kenya that are necessary for treating sex problems. The government will not import or buy them. They will not be put in health facilities. Even just training of health workers on how to treat some of these problems. The training institutions are not training people in it. Research around sexual medicine and sexual health is minimal. So there is a lot of work to be done to mainstream sex problems as health problems.
Okay, I had never thought about it through maybe because I'm in the West, and I thought we are training people in all aspects and all angles as to how to treat erectile dysfunction. Before we go to the treatment, I just want us to, because someone had asked a question about HIV. Could you touch on the two viruses that are annoying us out here, HIV and COVID, in relation to erectile dysfunction?
I think it's just for HIV, it is the psychological impact. The fact that when one has HIV, the stigma has always been a problem. People think you did something wrong sexually, and so that is why you're having HIV, and so on. I know that stigma is going down now, but it has been really big. So if someone becomes HIV positive, if they discover that they're HIV positive, the first thing they do is self-criticism. And the criticism tends to be more directed towards sex organs, that this is the source of my problems. And so people can have erection failure, lack of sex desire because of that stigma and self-criticism. that they got HIV from, sex. COVID, we've seen a lot of myths. We had myths like if you get the COVID vaccine, then you cannot, have sex again, you get erection problems. But from our studies, what we found, definitely there were more cases of erectile dysfunction during COVID. And the reason was because of the stress that came with COVID, the loss of income, the change in lifestyle where people are locked in their houses and all that. It had nothing to do with the virus or the vaccine.
Okay, so let's give people hope. So how do you approach a person presenting to you with erectile dysfunction, or one during your examination you discover has erectile dysfunction? What do you do?
Yeah, and I talked about the need for training. These are not people, they are not regular patients. If I'm seeing someone with malaria or pneumonia, I can take like 15 minutes, make my diagnosis, put on treatment, and that's it. Erectile dysfunction has medical, has psychological, has social effects. We have to go through that whole lot of discussion. We have to go to the root of the problem. We have to know people's beliefs around erections and sex. We have to assess their psychological status. So it takes time to reach a diagnosis of why someone is having an erection problem. The easier bit, of course, is the biomedical, checking whether people are diabetic, hypertensive, and all that, doing the necessary tests. But psychological and social assessment are equally very important, and they require time. And so normally, it takes even like up to 1 hour with a patient, trying to understand what this means to them, what they have gone through, what the causes could be, what the aggravating factors could be. And many health facilities are not set up for that. And also, if you're seeing a specialist, it costs money to stay with one person for that long. So yeah, but that is what it is, real detailed history, physical examination, some tests, and the history includes psychological and social assessment.
Saira, on your side, how do you approach
so in my practice, so like I said, most of the patients have a medical diagnosis, and then by screening is when we assess. We find out very few patients come out to tell us that, okay, I've got a problem with my sexual function. So this is what we do. So if a patient comes to me and we have got a diagnosis of diabetes, as part of routine in my clinic, what I've kept is a simple tool known as IIEF, which is the tool which is the international. What is the other? I am just forgetting the erectile function. So it actually assesses your international, I think it's index for erectile function. So it assesses, it's a very easy, like 5-6 questions, and it actually can be patient administered. So while I'm doing my notes and all those things, I'm actually telling the patient to be, or if the spouse is there, preferably, then they can sit together and fill in that questionnaire. And it's available online. And in my practice, even for females, I do that. There's a female sexual dysfunction tool that I use for my patients. So if I have a patient diagnosed with diabetes, a male, they do the IIEF tool. I ask them generally if they do have any problems with their sexual function, and they are the ones usually then they come out and they tell me, oh yeah, I do have an issue and I cannot maintain an erection, or I can't get an erection, and then assessing based on the tool, we know what is the severity. Now, before starting treatment, a couple of things that I always look at is what is their testosterone level. So always ask for a morning testosterone test, at least a total testosterone, so that it gives us some idea about the hormonal status. Because with diabetes, you could even get low testosterone levels because of various reasons. So we ask for testosterone levels. If the testosterone level is normal, so along with testosterone, usually I would still ask for also a thyroid profile to start off with, after getting a thorough history like Prof has already talked about, because the psychological element is extremely important. when it comes to erectile dysfunction. So chronic illnesses, like I was talking about HIV, but also with diabetes, just having the chronic illness puts people off from the sexual aspect, and they think that they need to pay more attention to other more important things like taking care of their sugars, taking care of their diets, of their weights, and the medication and all those things, rather than focusing now on. So they kind of tend to put sexual function far away. So first we assess the psychological aspect, and then we do these tests. So if we find that the testosterone level is okay, then we start now considering management aspect. But I think in my practice, the IIEF tool has really helped. What I want to say, and this is also with what Prof had said, is that there's minimal, or there's really significantly limited research from this part of the world, for the pure reason of the taboo or the stigma associated with discussion of this topic. But as the Kenya Diabetes Study Group, actually, we realized this, and we are doing a study now. We've already got the approvals and all, and we're starting the study full-fledged in about, we're actually looking at 3 facilities that will be now assessing patients actively and determining what is the prevalence for both male and female sexual issues, especially with men related to erectile dysfunction in our setup, because this is something that's not really talked about. It's something that we don't know about, but this is something that we are now gradually working towards. Yeah, so that's how generally if it's to evaluate, then that's what usually I do. Then depending on after the examination, what else we find is when now we tailor our investigations accordingly. Another group of patients, maybe Prof will address that later, is these patients who have like prostate cancer and have gone through surgery for prostate cancer. Then they've been put on, drugs which could suppress testosterone production, because that could further worsen or cause recurrence of the cancer or something like that. But those are another group of patients who at times I see, because if they have concurrent diabetes, then that's what, when in the process of asking, we realize that that's also another issue. So in that group of patients, then it's a little bit more challenging to treat for erectile dysfunction, and many of these patients do end up having it. Another very important group of patients to remember is those who have got some medication. So other than the medical conditions like high blood pressure itself, diabetes, high cholesterol, if you have those with obesity, some medicines also that are used to treat these conditions, including just benign prostatic hyperplasia, like enlargement of the prostate, which is a common occurrence in men after a certain age group as they age. And they used some medications are used to handle that, to improve their urinary functions. And those could actually precipitate also or worsen erectile dysfunction. So generally, when a patient comes to us, we usually take a detailed history even of their medications and see what potential medications they could be on, which could disrupt their erectile function. Yeah.
Okay, so I know we will treat according to the underlying cause, but Prof, just take us through the treatment options that are available in the market.
Yeah, and you have correctly said it, treat according to cause, but normally in my experience, there is never one cause. Assume, for example, that it is uncontrolled diabetes. The fact that erection has failed, people get psychological distress. They start questioning whether they are still men and so on. And then relationship problems also set in. The partners start to think that you are now lacking erection because you're having an affair, or because you no longer love me, or because I'm no longer as beautiful, and so on. So it might start as something very straightforward, but it ends up very complicated because of the interconnectedness of things. And so normally we say there is the symptomatic treatment of the erection failure itself. You might use some of those erection enhancers. Then there is background treatment of the biological problem, if there is any, whether it is diabetes or changing drugs that people are using for other things that could be causing erection failure, or hormone problems. You treat that as well. Then there is a lot of counseling that is needed for people to come to terms, to get understanding of what the problem is, to get reassured that they are still the man they used to be. And then a lot of therapy normally is needed for people to psychologically heal as well. And many times we also involve the partner because sometimes the reassurance from the partner is very important for healing to take place. And when erection failure happens, intimacy gets affected. And intimacy here, I mean just the ability to connect at an emotional level and also physically. Many people distance themselves, they avoid touch, they sleep facing away from each other and things like that. And so recreating intimacy and rebuilding the relationship also becomes very important. So there is medical therapy, there is psychotherapy, there is relationship counseling and couple therapy. There is recreation of intimacy and rebuilding of the relationship.
And I know someone has asked me about the Viagra. I know there are other pills on the market. So is it lifelong? Like if once you're on you've been diagnosed as having ED and your treatment includes Viagra, will it be lifelong or you can stop it?
It depends on what we are treating. It depends. Many times, if the cause is treated, one may not have to use it for long. It may be just for the time being as you recover from the cause of that problem. So if it was low testosterone and we are managing that, either by correcting why it is not being produced or replacing it, the moment that is done, you regain your function and we stop the enhancing drugs and you can function normally again. So it all depends. If there has been a lot of damage to the system, say because of diabetes or other things, and it is becoming impossible to regain full function, then one may have to use it on need-to-need basis.
Someone has asked about Procomil. I don't know what that is. Is it okay? I don't know what Procomil is.
Procomil is yohimbine. It's one of the chemicals that it doesn't work like Viagra, but it's we call it a sex tonic. It helps in re-energizing erections, if I put it that way. Yeah.
Okay.
It's okay, but some of these drugs, whether it is sildenafil, the Viagra, or tadalafil or others, they need to be used ethically for good reason and on prescription, because if not used correctly, again, you end up with other problems. They are very good drugs, but they need to be used ethically for the benefits to be achieved.
I know Dr. Saira had mentioned patients who are recovering from prostate cancer surgery and those ones who are on medication for enlarged prostates and their ED status. Is there hope for them or it's a done deal? Like if you're putting them on alpha blockers for the or medication for the prostate and medication or surgery for the prostate cancer, is there hope for them or they'll just be there?
Yeah, so we have a big agenda around sexuality and cancer. Very big. It's big because there are a lot of issues around sexuality and cancer. The moment one gets cancer, the first thing they're thinking about is whether they are going to live or die. And many health workers focus on that and stop looking at the person wholesomely. So whether it is prostate cancer or other forms of cancer, sexuality gets affected in a very big way. Remember the stress which comes, you don't know how to relate with your partner anymore, whether even to give attention to the whole issue of sex. And many times the partners are also wondering whether this is the end of marriage and other things. So other than the drugs which are used for prostate cancer or even the surgeries, there is a lot more psychotherapy counseling, couple counseling that is needed to just make this person understand how to live going forward. But there are now many interventions. If we cannot use the drugs, I have a few prostate cancer patients, and they're using the drugs which work against testosterone, so the erections are a problem. There are other things now that can be done, including surgical, just to have some form of erection to make someone continue living a wholesome life.
Saya asks, what affects testosterone production and how can it be boosted or improved?
Well, so we've just talked about one of them. Some cancers, when we are treating them, especially prostate cancer, you can be given medicine that works against the testosterone. One thing that surprises me is how much we know about our bodies. I've met men who have one testis or who have no visible testis, who are married, they cannot get erections, so their wives cannot conceive, and they're discovering for the first time in over 30 years that their sex organs are abnormal. There are abnormalities that happen around the sex organs and they affect the production of testosterone because testosterone is produced in the testes. If, for example, one has undescended testes, the testes are not visible outside of the body. With time, it can affect fertility, it can affect production of testosterone. And the earlier it is detected and corrected, the better. But many people don't know this. Sometimes even things we call varicocele, the veins around the testes, holding blood for too long, the temperature around there not being okay, will affect the function of the testes. I would want to say this, testis health needs to be a man's priority. You need to know that your testis is okay. When we see women and we are doing a well woman clinic or a gynae check, we always do an ultrasound scan to check are the ovaries okay, is the uterus okay. Men rarely get their sex organs checked. Very few men, if at all, have ever had a testis ultrasound just to see if things are okay there. So problems of the testes can lead to low testosterone. And Saira earlier on also talked about hormones and especially the pituitary, which is based in the brain and controls hormonal functions. Any effects, any problems with hormones, which could be coming from the brain or from other organs that produce the hormone, can lead to problems even with testosterone. If the brain is not stimulating the testes, then the testis does not produce the hormone. Yeah.
Saira, the question I had asked Prof earlier, as in terms of treatment, what do you offer your patients? I know it's per patient, per condition, but generally, what's your spiel?
Yeah, so of course, with the lifestyle changes that we give to all our patients when they have got diabetes or obesity or lipid problems is related to, the healthy kind of eating, reducing your carbohydrate and caloric intakes to what is required for you. And that also is usually very individualized, depending on what kind of weights you're looking at, how the sugar control is, what excess you have, what is available to you, what is affordable to you. And then physical activity. So there are a lot of studies which are showing that improved physical activity, and we are looking at just at least 30 to 45 minutes of physical activity, which includes both endurance training, like the cardio workouts, and resistance training, but not overdoing it, because even overdoing it can affect your sexual function. By the way, if you overdo with physical activity, especially in women, you can get menstrual issues and all. But physical activity of 30 to 45 minutes literally improves your erectile function. So that I've experienced a lot with my patients. Once you put them on the right kind of lifestyle, now in addition to that, you will add other medications. So basically, once you have ruled out that they don't have a testosterone problem, if they do have a testosterone problem, then you give them testosterone supplements, which would usually be intramuscular in our setup. We've got the injectable one, but there are also testosterone gels. There are also testosterone tablets that are available out there. So you'll treat that testosterone problem first. And now, in addition to that, we would give them now treatments like there's either sildenafil, which in my practice I don't use so frequently. Frankly, what we go for is the longer acting shorter, like smaller doses related medical therapy, including tadalafil. There's something known as tadalafil, which is the Cialis or Talgentis, the brands that are commonly available in Kenya at least. So that's like you start at we usually start at a small dose of just 5 milligrams, and then as needed, depending on their performance, we would advise accordingly to take a higher dose or not. If they still don't improve, even after doing all that, improving their lifestyle, achieving a bit of weight loss, improving their exercise levels and physical activity, and also undergoing psychotherapy, because that's extremely important. We have to sit with them and discuss. So there are lots of, some of the patients, they tell me that they don't have an erection when it comes to their regular partner, but when it is out of marriage, then those are the things sometimes then we end up doing even couple therapies to be able to see how to handle these kind of situations. So in addition to that, now, if they are not improving, then that's the point that we usually refer them for urology evaluation. At times, not only urology, but at that point, in fact, even at diagnosis, like I said, if I find a patient who has erectile dysfunction, then I'm very much worried about their heart and the rest of the blood vessels of the body. So I get a cardiac assessment done in all these patients. Either way with diabetes we do, but when they have erectile dysfunction, then we're a little bit even more aggressive. My patients, I even make them go through an exercise stress test just to rule out any blood flow problems in the heart. Because why does diabetes cause erectile dysfunction? Is, you see, diabetes causes blockages in the blood vessels supplying your body. Because in very lay words, is sugar is sweet, right? So, and sticky. So it sticks to the blood vessels and it pulls with it cholesterol or fat that is circulating. And that kind of thickens and narrows down your blood vessels. So the blood flow is reduced to the sexual organs, but then that is also happening then the rest of the body, yeah? So that's another evaluation that we necessarily include in patients who've got erectile dysfunction, in especially if they've got coexisting conditions like diabetes or hypertension or cholesterol problems. So, and then again, we'll put them on medication to control cholesterol levels. There's some blood pressure medicines which can affect your sexual function. So we'll review their medical profile and see what it is that we can substitute or change to help with improving the sexual function. Yeah, sometimes even send them to cardiologists for blood flow correction issues, because if they've got blockages, then now we've got therapies which can actually balloon up the blood vessels just the way it happens in the heart. Or reconstructive vascular therapies can, in specialized centers, be taken care of. But mostly we send them to the urologist, who then do the evaluation and then decide if there's a medical, if there's a need for cardiac or rather vascular intervention. Prof, you can add on to that.
Yeah, I wanted to say, the whole issue of, well, in medically, we call them atheroma, the blockage of the blood vessels is very important. So of late, we are also starting to use shockwave therapy. I think there are only 2 machines in Kenya to unclog. But I think the important thing is that because we are doing mostly that for the penis, when you're having erectile dysfunction. But the most important thing is that this is a systemic problem. It's going to affect your heart. It's going to affect other organs. And so treating this whole person is very important beyond just the shockwave therapy in the penis. Yeah.
Okay, I know we had covered the myths because someone has asked about the diaper. Could you just, brush through, the diaper, nduthi, hot showers, microwave, phones, the whole shebang, and erectile dysfunction? Is there a correlation?
Well, there are many things you've mentioned.
If I don't say
Yes.
them, they'll disappear from my head. So, okay, so
Yeah.
nduthi, diapers, hot showers, because I've had all this, microwave, phones, and all that. Is there a correlation with impotence and erectile dysfunction?
Do these motorcycles for those who may not?
Yeah.
Okay.
Yeah. The motorcycle riders, actually, we are yet to do a study in Kenya, and it's something I'm working on. But elsewhere, what has been shown, because of the vibration and the heat that comes with the motorcycle riding, those who do it for long hours can have erectile dysfunction. Now, the proportion is what I'm not sure. We need to do our own studies here to be sure, but there is a risk there, definitely.
Diapers, okay, yeah, diapers.
Diapers, well, anything that increases temperatures around the testes. God allowed it to hang out so that it can cool, because for it to function well, it needs lower temperatures than what you find inside the body. So if the temperatures around there are always raised, that can be an issue. Again, I don't have scientific evidence to show how diapers can affect, but logically it might, because it's like putting a blanket around there and the temperatures then go up. Shower using hot water, really, you do that for a very short time. I don't think I would be worried about that.
Mobile phones?
I don't think there is evidence on that. I've not seen any evidence to implicate mobile phones and erectile dysfunction, and also microwave, which you mentioned.
Okay. And in terms of, because I know you've mentioned the urologist, in terms of the dream team, if I have erectile dysfunction in Nairobi and middle class and above, where do I go? And if I have erectile dysfunction in Ebshibungo, that is my upcountry place, who do I see? I'm just saying this because we know of the social strata in our country. Who do I see in Kenya? If I'm for lack of a better word, nguvu zangu za kiume zimeenda, if I can afford it, who do I see? And if on the lower social strata, who do I see?
Let me look at it from a medical service delivery perspective. What we in sexual medicine recommend is that we work in teams. So a sexual medicine person like me works with a urologist, works with a gynecologist, works with a psychologist. In fact, we even work with priests and other leaders of religion, because occasionally you find that you need to extend the counseling beyond the health facility. We work with physiotherapists. Sometimes we do pelvic physiotherapy and things like that. So someone who specializes in treating sex problems, what we recommend is they form a team that they cross-refer to, because sometimes one person cannot treat everything given the complex nature of the sex problems. I work for Amref International University, and we are going to be starting a fellowship program in sexual medicine that helps one know when to call in who. Health workers in the front line basically need to have basic knowledge on treating common problems, but also they need to know who to refer to for what case. I can tell you, in your village and even in Nairobi and in big cities, most of our patients with sex problems go to see health workers and they are told it is psychological, it will end. And that's all the treatment they get. Or they are told, here we don't treat such things. We don't believe that's a problem. You will be okay. There is need to train frontline health workers on basics of sexual medicine and also to help them know who to refer to, whether they are in the village or in the city.
Okay, and I know you alluded to the lack of uptake of the Wellman clinics and checking the testes and everything. So beyond, because I know after the measles vaccination, that's the last time most people see the doctor, the measles vaccination in childhood. So, but for women, at least we go back because we get pregnant, and at least we get a checkup in our 20s and in our 30s. But for men, what would you encourage them to do to bulletproof themselves and to just make sure they are okay? What would you want them to do in terms of knowing their physical body well, and which checkups do you want them to do to just make sure their flag rises to the occasion?
Yeah, and you've put it very well, because after measles vaccination, the boy child, if they don't get pneumonia, they don't go back to hospital. The next time they go back, it will be because the prostate is blocking urine. They can't pass urine, or they're having erectile dysfunction or some other sex problem. What I would recommend, and what I normally recommend for both men and women, before you become sexually active, it's okay just to do a sexual health check. And that involves a lot of things, both biomedical and social and values and all that. When you're changing partners, it is important to do a sexual health check. There are some quiet diseases like chlamydia, which are passed on from one person to another without knowing. It is always important to, before you start a new sexual relationship, just to be checked. HIV, of course, is there. But there are these other things, even like erectile, whether you really have the right hormones and so on. So changing sex partners, yeah, very important, get checked. But I also normally recommend just an annual basic health check for men. The Wellman Clinic needs to be there the same way we have the Well Women Clinic. Things like prostate cancer can be detected very early. We can check them during the Wellman Clinic. Things like those worries that we have. Men have a lot of worries. Am I ejaculating too fast? I think the commonest problem from childhood all the way to when they are married and beyond is, my organ okay? Is it the normal size? Or I need to do something about it. So those things can be answered in the Wellman Clinic, and annual checks, very important for me.
Dr. Sarah, same question.
So unfortunately, like Prof said, we don't have sex experts in the country as such. In fact, I think they're extremely limited, maybe not more than a handful. So it would be difficult for everyone to go seek opinion from a sex specialist to be able to understand what to do. What I think is education is extremely key, obviously, and I really appreciate that you have taken up these topics and we are openly discussing these really important life-changing or, relationship-changing situations and understanding them. So most importantly is to talk about it, first of all, I think, out there in the public, right? And also to healthcare providers. So education to healthcare providers is extremely key. And that's why I said even research locally is another aspect of what we have on our plates to be able to deliver to the Kenyan population. And that's what some of us are already looking into. But now who to refer to? So at least at minimum, I know in our training, at least being a physician, after that I became an endocrinologist, but just being a physician, I know that we do have a session or teachings on sexual dysfunction, and at least erectile dysfunction is definitely covered in most physician topics that we discuss. So either a physician, at least a physician, that means someone who has done a master's in medicine, in internal medicine, would be someone who can understand. And I think most healthcare facilities, at least at level 3, level 4 levels within the country, do have at least a physician, or a referral facility which has access to a physician would be able to at least understand and ask for a testosterone at minimum, rather than our GPs or our clinical officers who don't truly get this education, like Prof was saying, within their training on erectile or even sexual dysfunction. So that would be a good starting point in any facility. But where we can get access, of course, going to a sexual health specialist or a urologist at minimum for men would be a good starting point in a facility where you can get access to. But where you can't, at least going to a physician would help quite a bit, or even a general surgeon. Someone who has done, a level beyond just doing basic medical training. One thing I want to point out here at this point, Posa, is that testosterone is not the treatment for erectile dysfunction if you do not have a problem with testosterone. One thing that we have to really understand is that, this whole aspect of going and, injecting yourself with testosterone and these other therapies that I talked about, the androgens, the androgenic steroids that people are using left, right, center. What happens is if you take testosterone externally, and if your body is producing its own testosterone as well, literally the external one will suppress your body's own testosterone production. But not only that, but it will suppress your pituitary gland to even produce sperms. So not only will you in future, once you stop the medication, probably not be able to hold your erection, but also not be able to father children. So that's something extremely important as a message that I'd like to deliver very strongly out there to all our listeners today, and even whoever else can be delivered that message to, is that these things eventually can harm you if taken in the long term.
So my last question, by the way, is so how do we address the issue of stigma? What I know partly it's these conversations that are on like Facebook Live, but how do we address the issue of stigma so that our men and women can stop suffering in silence? And any of you can take it.
So while I'm still unmuted, maybe I could start that. And I think the whole aspect is literally, boiling down to education. It is how we as healthcare providers first educate healthcare providers on the topic, because the stigma has to first break at healthcare provider level. So which includes not only as specialists, but also at the lower levels, because of the widespread availability of these agents, because of the changing sexual practices that we have across the globe, not only in the Western countries, but also in our regions. And I think that is so crucial because we will be facing more and more of these issues coming in at younger and younger ages, like Prof was alluding to. So the whole aspect of educating healthcare providers is very, very key. I'm so glad that AMREF University is bringing in these courses as part of their curricula. So it should be part of curricular teaching. Because our healthcare providers need to know what sexual health is and how to identify sexual dysfunction, yeah? And secondly is the public education that we are doing right now. But I think beyond just this platform, as you rightly point out, I think it needs to go to a wider audience. And that could be due to not only social media, but also through mainstream channels. I really don't know how that would be possible, but this is topics that, like personally, I would never mind going and talking about it even on television. Whenever I'm given a topic to talk about diabetes, then somehow I bring this topic in so that people understand it's not something that you should shy away from, and it's something that you should come out and discuss, because it's a disorder or a condition that you can seek treatment for, and which could, like basically be the starting point to a lot of other conditions that we may not know that you have. So I think to break the ice is most important, is through a lot of education. I don't know what else Prof would have to add to that.
Prof is already doing public education. He has a column on The Nation. He's doing his part. I don't know. I don't know any, Prof, I'm speaking for you, but just go on.
Yeah, I think, yeah, you are right. Education is very important. So I do the column every Saturday on Women's Magazine of the Nation. Initially, people were a bit worried. The editors were a bit worried that this can be seen negatively. And so they used to edit it quite a bit to make it more acceptable, in quotes. But with time, they realized that people liked to read that column. And I think it's among the popular ones now. And they want more information. As long as it is professionally given, it is very acceptable and nobody has complained to date. I also do a lot of radio and TV on sexuality, and I do a lot of physical meetings. I'm invited to groups in churches, in social groups, and we always talk about these things. So we need more people to do this. From the education perspective, the university that I work for, we are working on this curriculum with the International Society for Sexual Medicine, and we are coming up with a fellowship program for 1 year for practicing health workers, doctors, so whoever comes across people who have a sexual health complaint. What we have learned, what is known globally, is that many patients want their doctor to talk about sexuality. They are waiting to be asked about it. They are hoping someone will ask, and sometimes they're giving hints, but many health workers do not take those hints, and they do not want to talk about sexual health. And we think it is because they have not been given the necessary knowledge and capacity to do it. So training is very important for health workers, as we also do the mobilization in social groups, in the media, in professional groups about this. Yeah.
Okay, my questions are done. Saya, do you have any questions? And the panelists, is there anything I missed out and you wanted to talk about?
Yes, Paul, I'm getting, yeah, naturally, some men have shied away, but they are behind in the tent me. So I'd posted a question there, which was, what's the effect if outside of the risk for STIs to men, we've discussed previously to women, but what's the risk to men for having multiple sexual partners, people who are going around outside of the STIs? And the second addendum of that is, does it in any way play into the whole erectile dysfunction story?
For me, it's just what I said. It is very important to know your values and to live those values. You need to make sure that your behavior and your values match. Whenever they are not matching, you get internal conflict. That is the beginning of many disease problems, including erectile dysfunction, anxiety, and other issues. So whether it is multiple sexual partners, whether it is polygamy, whether it is sex before marriage, all those things, I know people have their values. Make sure you live your values. That is the most important thing.
Hey, Prof, the follow-up is, so I'm just speaking, I need to give you more context for that. The questions are coming from places from forums where we don't share the value. So there are people who their value system is, as long as it's breathing and it's in a skirt, I can sleep with it. And in the same forum, there are people who are a one man, one woman till death do them part. And therefore, the question has degenerated to, from a medical standpoint, what's the risk, STI, and if any other risks do exist in people having multiple sexual partners?
So the biological things, we know them. So I'm a Christian, but I treat Muslims, I treat Hindus, I treat other people. And our Muslim brothers, for example, are allowed by their faith to have 4 wives. And that is very okay for them. But in terms of ensuring that those multiple sex partners, and I know even beyond religion, beyond Christianity, Islam, and others, we have African culture, and there are people who are in polygamous marriages. We hear of 7 wives and others. We know there are communities where it is allowed to some extent even to have secret wives. You know, you talked about language. When you have a language that describes a secret wife, that it means it is something that community recognizes. So there are all those things. But what I would say medically, just like I said before you get into a sexual activity with someone, before you start a new sexual relationship, it is very, very important to ensure there is no disease. So we talk about sexual health check. If you don't want pregnancy, for example, it is very important to ensure that you're not having risky activities that can lead to unwanted pregnancy. But the bottom line for me, know your values, live your values. And those values differ and all that. But medically, if it is multiple sex partners as a value for you, make sure that you've done the necessary tests. You are not having diseases that you can pass to other people, and your people cannot also pass to you. And as I said earlier on, from a sexological perspective also, I've seen sharing love is very difficult. And some people have what we call situational ED, where they have ED with one partner, but not with another partner. Basically, sharing love is not easy. So all those factors one needs to consider before they take action on these issues of sex.
Are my attempt questions done?
Yeah, there's one more you might attend question, which is Doc, not Prof now, Doc. Doc, the curiosity from behind the tent is the assumption is you're Muslim and you're female. So part of the curiosity is how do you get Muslim men to A, talk about erectile dysfunction, and B, come and get the attention, knowing part of the separation and the conservative side that faith can have, and more so in Islam. I think the wider angle for that question is how to practically get men involved and interested in having the whole medical checkup. But over to you from experience.
That's a very good question. And the truth is, it's not only from a Muslim perspective. Actually, the Kenyan perspective itself, like I said, is the health-seeking behavior for sexual health is very poor, I believe. We don't have the exact numbers, but personally, I believe it's just not, people don't come out and tell you, I have this problem, especially when it's a man and they are coming to see a female doctor. It doesn't come out easily. So what I do is I actually actively ask. So I'll start with asking, for example, if a patient comes in and they've got diabetes. So I start by asking about all other complications of diabetes, which I'll start with do you have an eye problem? Do you have a skin problem? Do you have a problem with your heart? When was the last time you got an eye checkup done? Do you have a kidney issue? And then I'll tell them, as part of the complications of diabetes, I'll have to ask also about some personal questions. And I broach it. I actually directly ask them, do you have any issues in the bedroom? Do you have a problem with your sexual life? And this especially, you have to be sensitive, because the problem is you have to develop a good rapport before you bring out these questions to any patient, basically, from what I've experienced, because of the cultural aspect generally. But if you shy away from it, then it will never come out. Yeah, especially with certain cultures, like you said, the Muslim culture. So what we have to do is make sure that either they are with their wife, the patient has come in with their wife, or they are alone. And so that's when you broach obviously you have to take care that they're not with their son or their daughter. And that applies basically to any patient. So usually we even request like in the first visit, sometimes if I see, depending on how the cultural diversity or how acceptable culturally it would be to that patient, then I basically would broach the topic right in the first conversation. If not, then I first develop a rapport with the patient, develop their confidence, make sure that they are able to discuss with me all the other aspects. But basically, from the beginning, we start discussing these issues. And like I said, I usually even give them the questionnaire and tell them, look, this is a very common complication of diabetes. Or if they've got pituitary problems, this is a common problem that is found in patients up to 50 to 75%. And it would be necessary for us to ask about it and discuss about it, because this can tell me that this is how your overall cardiovascular health is. So I bring it up in a very covered yet exposed manner, where they don't feel like they're being, accused or intimidated or directly targeted and being told that this is not okay, like your sexual function is not fine, and for them to understand where I'm coming from. I think it's important for the client or the patient to understand where you are coming from when you're asking that particular question. And trust me, I pick numbers like anything, because this is like, even in my typical history, it is there, it's slotted in. So we definitely ask them directly. And it's not something to shy away from. And I tell them, it's not something you should shy away from. And a lot of Muslim male patients actually respect you for that at the end of the day, because you're looking at them holistically, not only, like as a block of sugar when they come with diabetes. So we start with their psychological aspect, their family aspect. How many children do you have? Do you have only one wife? Because in the Muslim culture, like you said, it's important to understand that as well. Sometimes you realize that their function with one wife is different compared to the other. And I really like the way Prof put it, that love sharing is not really very easy the way, and that's why there are conditions, even in the religion, on what conditions you'd have to be having more than one wife. But regardless of that, basically, these topics have to come out by us directly. Otherwise, the patients usually don't bring it out. I hope I've answered you.
Yes, I usually go off screen because I'm doing the behind the tent question. Man, interesting. Final question from behind the tent is, I don't know who'll pick this, is, so when does a man decide he has or needs to be checked for the erectile dysfunction? And the context for that is, how do they distinguish between, I'm just having a bad day, I'm just having a bad 2 weeks, or I have an erectile dysfunction? When should they become concerned enough to check in for that? I don't know. I suspect Prof will go first.
So I would say that anytime it worries you or it worries your partner, then it warrants attention. It needs to be attended to. There are situations where, because of a stressful day and all that, an erection goes, it's just once in a while. But so we would not even define it medically as erectile dysfunction. But if it is worrying you or your partner, and if it is causing disharmony in the relationship, it is very important that you seek care.
Okay. Sai, your behind the tent questions are done.
Yes, my behind the tent questions are done.
Okay, Syra and Doc and Prof. Okay, we'll go with that. Doc and Prof, if there's one thing someone should take away from this whole conversation, what is that?
Okay, I would want to share my perspective with everyone that these problems are medical, they can be solved, and that is the perspective I would like to sell out there as well. So if you happen to have any of these sex problems, erectile dysfunction being a very common one, just seek help. I know there are not many doctors trained in this, but there are doctors. Maybe I would also add that, Saira, there are also a number of untrained people who are giving information and even remedies that can also be dangerous. So let's use professionals who are trained in this line to solve the problem. Yeah.
And Prof, while you're still there, I think someone asked about the training. When is the program opening and what will be their requirements? And lastly, if you could just share your reachable, as in how do we reach you to talk to you about these matters? How do people see you?
Okay, so I work for Amref International University. This program is going to start in January. We are just finalizing the reviews. It's going to be a global program. So right now the reviews are with the International Society for Sexual Medicine, and we hope that in January we can have students. And basically we will be aiming to train frontline health workers who are who come across people with sexual dysfunctions. There is a training at different levels. There are those who are given sensitization to be able to treat common problems and refer. And then there are those who are at a higher level who treat the more complicated problems. So that is coming. How to see me? Yeah, I do have a clinic in Nairobi. Maybe I can just put the number of the clinic in the chat so that if anyone needs to contact me, they can call that number and they will be given a booking. So I will just write it in the chat.
Okay. Saira, you're up. And meanwhile, someone has asked, how does a man improve his recovery time after the first try? Jesus or Jesus? First try shot ya kiherehere or first try first sexual encounter. Just clarify that. Saira, go ahead.
Any person, somebody has called himself Jesus, and that's a kind of way you're putting it. Okay.
I said Jesus. It makes me feel better. Yeah.
That's not a question I'll answer. Maybe I'll just go with my take home. Yeah, I really don't know. I don't know the answer to that. Maybe Prof will take it once he's back. So my take home is exactly what you have said as well, is let's break the stigma around sexuality and sexual health. Actually, very recently we had the World Sexual Health Day. So now, there is a World Sexual Health Day, just so that people can discuss the issues that they're having and create awareness about sexual health. And let's discuss it, because it can really significantly impact your life, as I said, with cardiovascular health, and also your relationships. Because psychologically, if it impacts you not only through cardiovascular health, but also it can significantly affect mental health, with increased chances of depression and suicide and stuff like that. So let's address these issues. Seek help if you have a problem with your sexual health, based on whether it's an erection problem, whether it's an arousal problem, whether sometimes the libido is low, or whether there is a problem with ejaculation. Please seek help, because these are medical conditions which many of them can be corrected. Like I said, it starts from any doctor as first line, and then can go to the urologist, can also reach all the way to cardiology to be able to manage, or cardiovascular specialists. So seek health. Let's break the stigma around sexual health. One thing I'll tell you is what started happening is just a very interesting story, because of the question that I received earlier. Is as far as Muslim patients are concerned, there was an elderly male that I actually broached with this topic, and we helped him and gave him medication and education, and his sexual health, actually his erectile dysfunction, improved significantly. And after that, actually I started getting a lot of referrals related to that, and people actually started coming and talking about it. So that's also something that once they realize that you are receptive, like Prof said, then they will bring it to you. So thank you so much. Thank you for this awesome discussion, Prof.
Thank you.
And Prof.
Prof, I feel like this question by Jesus needs like a consultation. This one is more than just I don't think you can be given an answer directly. I think we need to eat, as per my tribe, we need to eat. So saa tufungie mkutano.
Okay, I'm just making sure I don't have any new may attend things before I pop up. Okay, here I am now. So thank you, Prof and Doc. That's easier to remember. For making your time to be here and to speak openly and without fables. I think sex in Africa is talked almost the same way people talk when they're going for bride price. You've all come, you all know, you've all been expected. But when you arrive, you just can't come straight and say, we've come because we want this girl. You have to keep going around the bush. So thank you, because one of my professors once told me, vagueness is not friendliness, vagueness is the enemy. So thank you for not being vague. And thank you for putting in your intellectual and experiential power to help make this discussion clear. Thank you for clearing on myths. And thank you for pointing out, more importantly, and most importantly, to solutions. We want to believe we are made them more wiser and smarter because of your combined efforts. So once again, thank you. Thank you for everyone who's made it to be on the Zoom call. Your time and presence and questions made it worthwhile. If for nothing else, the panelists didn't feel they were just talking to the air. They knew there were people there to address. So thank you for being there. For those who will watch this later, whichever the platform, Facebook or YouTube, again, thank you for just making the time to invest at least in your knowledge about your health, and hopefully you will take the requisite steps should it become clear that those are needed. Yeah, thanks to Pose for being the panelist, and thank you, sir, for being a co-panelist for all of that. Our next topics, the topics almost seem curated nicely, because last week we were talking about medical gaslighting. This week we've talked about erectile dysfunction. In another 2 weeks, our next session is going to be in October, because we've had our 2 September talks. So we're having our first session in the first weekend of October. That's the 6th of October. And we're going to be dealing with the question of shame. Okay, we're going to be dealing with the question of shame. So whether you're dealing with shame privately in your life, or especially many of us, majority, come from shame and honor cultures, how is that affecting us? How are we navigating shame? How does that contrast with, for instance, biblical concepts like guilt? Yeah, and just dealing with the whole idea of shame, the weaponizing of shame, the using of shame to put people down, and how to overcome and recover from shame. So please do make a point to be there. And in the interim, you can make our lives sweeter by sharing any questions or experiences that you have with the topic at hand. Things, please, Syria and Prof have done a good job in giving us of their 2 hours of their time. I think the least you can do is, should you deem that you need their services, please do reach out to them and please pay. Okay, we are actively trying to discourage the culture of getting something for nothing, because people put in time. So I think the only way you can support them and a way to say thank you is reach out to them and please pay for the various services you need from them. No, they don't take exposure. No, they are not paid by likes. No, just pay and use their services. Okay. Then secondly is, please support our work we are doing, and how you can do that, there are various ways. One is by suggesting topics and or speakers whom you want to listen to, and we will do whatever it is within our power to facilitate that. Secondly is, please like, share, and subscribe, and also give feedback to our social media handles. That is Instagram and TikTok is One Sire Jackson. On Facebook, it is Authentic Dialogues with Sire Jackson. And YouTube, just look for Authentic Dialogues, or look for a second YouTube channel called Sire Jackson. Your presence on any of those platforms and continuous support there is highly appreciated. After this vote of thanks, we normally have a section for the people on Zoom. We call it Behind the Tent, where for the people who don't want their question or their presence, go offline, and we just spend time on Zoom, and you can ask questions at that level. It's brief, it's shorter at that point. And so if you want to have a consultation, then you can remain behind. Otherwise, thank you again. And we hope people's flags will begin going up when the anthems begin playing. And I hope that marriages that have been sexless will experience a better sex life, and individuals who've been careless or presumptive about their sexual health will be able to take better charge. So be blessed and God bless you. Back to you, Paul.
Bye-bye. The Behind the Tent will just be 5 minutes. If you have a question that's burning and you feel like it shouldn't make it on the interwebs, just ask, or if there's no question, we will end the whole conversation. Thank you. And thank you to the people who provide us the panelists. So Dr. Saira, it's courtesy of Dr. Hussein, and Dr. Professor Osur is the courtesy of Dr. Wala. Thank you very much. Our flyer person is Kip, courtesy of my friend Grace Nzula. Asanteni sana.